Good afternoon. I am delighted to welcome you to our first session in our Menopause Roundtable series, The Realities of Perimenopause and Menopause, what it really means for women. We are so glad that you are here. First, I'd like to tell you about my organization, Healthy Women. For more than 30 years, Healthy Women has remained true to our founding mission of creating and disseminating evidence-based and clinically sound health resources tailored for the unique and often overlooked health experiences of women ages 35 to 64. We have content on all areas of health and wellness, from diabetes to cancer, heart disease to osteoporosis, multiple sclerosis to sexual health. I invite you to visit our website at healthywomen.org to learn more and to check out all of the resources we have available on these topics and more. Menopause. Menopause is such an important topic for our audience. We recently conducted a study with WebMD called Aging Smart, Aging Well. It was one of the largest surveys done on midlife women since the 1990s and the Women's Health Imperative. We found that menopause has a significant impact on the health and well-being of a majority of women, that women are still as confused about menopause and hormone therapy as they were 23 years ago. Only 1/3 of women reported talking about menopause symptoms with their healthcare providers. And while the same 30% did not discuss the topic at all. Even worse, 50% of women still find the topic taboo. Even more barriers to comprehensive menopause care exist for Black and Brown women, who are less likely than white women to be screened for bone and other menopause-related health issues. Women who experience other socioeconomic stressors may experience even an earlier onset of symptoms, and underinsured and uninsured low-income individuals often lack access to care at all. This roundtable is vital to flipping that script. Women need to talk about menopause, and we want to talk about it, even before we reach the stage of menopause, so that we can find the best ways to prepare for these changes, manage our symptoms, and improve our mental health and wellness. Aging smart and aging well. Today, we will be covering the basics, and then each week, we will dive into specific areas of menopause so we can have all of your questions answered. I hope you will consider joining us for our additional sessions throughout the next 6 weeks. My hope is that you leave each session feeling more empowered and informed. And finally, I would like to thank Stellis and Genev for their support and their investment in women's health. Now, I am thrilled to welcome our esteemed panel of experts and today's moderator, Wendy Lunn, a good friend of Healthy Women and a personal friend of mine. Wendy serves as the CEO of GCI Health, a global integrated healthcare communications agency. And now I will turn it over to Wendy. Wendy, thank you.
Thank you, Beth. It's great to be here with you. And yes, we have a very, very long friendship for many years. And yes, it all began in that grove in Shrewsbury where I knocked you down and said, can we talk about menopause? So I am very, very happy to be here today. One of the reasons I'm so happy to be here today is that, in thinking about this, as women enter menopause, there is so little information, and I am so happy that Healthy Women has taken this on as their mantle and is bringing as much information as possible to women. I remember the day that I first got my period when I was about 12 or 13, and my mother packed me up and she threw me in a car and said, we're going to Bloomingdale's and I'm going to buy you some clothes and a diary because I want you to write everything down because you're now a woman. And she was so proud and happy. And, umpteenth years later, when I entered menopause, nobody talked to me. There was nothing to read. I had no one to talk to. So it is time to kind of open that up and, stop being in the vault and really get women to begin talking about this, about all the differences, because, you know, all those years I also had endometriosis and had 2 children, and I would have loved for my period to turn into a comma. So I was very happy the day that my period ended, and I was able to really celebrate going into menopause versus dreading menopause. So I hope that for women out there who are thinking about it and are in perimenopause, you can look at menopause as more of an entry into a new part of your life versus something to dread. And I know that my esteemed guests here, and I'm in awe of the women I'm here with today because they are going to share so much. So let me start by introducing them real quickly. First, we have Omi Shadeh, Bernie Scott, and I hope I said that right, Omi Shadeh. Yay, I practiced.
You did good.
Yay. And she's a Black Southern 7th generation native North Carolinian feminist, mother, and healer. And Omi Shadeh has spent the better part of the past 25 years of her life focused on the liberation of marginalized people, beginning with her own community through advocacy work, philanthropy, community organizing, and culture work. She is the creator and curator of the Black Girl's Guide to Surviving Menopause and a multimedia project that's seeking to curate and share the stories and realities of Black women and femmes over 50. So welcome, Omi Shadeh. I'm sure you're going to add a lot to this conversation today, and we're thrilled to have you. Next, we have Dr. Octavia Cannon, who is a board-certified physician and co-owner of Arboretum Obstetrics and Gynecology. And this is the lone private practice in Charlotte, North Carolina, with only female physicians. So women in North Carolina, in Charlotte, make sure you make your appointments there.
It's Arboretum.
What's that?
Arboretum.
Arboretum, sorry. And Dr. Cannon was the first African-American president of ACOG, the American College of Osteopathic Obstetricians and Gynecologists, in 2018 and 2019, and also served on the board of directors for the Florence Crittenton Services, which is committed to assisting pregnant and at-risk young women support their families. And she's also a charter member of the American College of Obstetricians and Gynecologists, Women's Preventive Services and Initiative. Welcome, Dr. Cannon. We're thrilled to have you here.
Thanks. Hello, everybody.
Finally, a woman that I go way, way back with. We actually launched Depo-Provera many, many years ago together in the late 90s, I think it was. And I've always admired her and done a number of campaigns with her. So happy to return to Dr. Mary Jane Minkin, who is a clinical professor at the Department of Obstetrics, Gynecology, and Reproductive Sciences at Yale University of Medicine. For her first 25 years of practice, she delivered babies, and I'm sure she did an amazing job and probably delivered many of them. But in the last 16 years, she has taken care of patients whose children she had delivered as they grew older, and as such, she does a ton of work in the area of menopause. She teaches undergraduates at Yale, medical and physician's associate students, residents and fellows, and her colleagues about menopause and sexual health. Along with one of her chief residents, Dr. Minkin started one of the first programs in the US for menopausal issues for cancer survivors, which is really important. And she's also established a website, which we were really tickled by, which is for menopausal and perimenopausal women, called Madam Ovary, forget the B.com. So Dr. Minkin, it is always a pleasure to be with you, and I am just so happy to be back in your place, in your space again. So happy to have you all here. So I'm going to start. I know we don't have too much time, but I'm going to start with my first question, because I think a lot of our people that are watching this are always afraid to kind of ask this first question and really don't really understand what menopause really is. So Dr. Minkin, can you define the terms perimenopause, menopause, and postmenopause so people really understand what we're talking about?
I'll try my best, Wendy. Thank you. And again, a pleasure to be here with everybody. So can I start with menopause? That's probably the easiest definition to go with. And in somebody who has a uterus, and I have to define that because indeed, if you've had a hysterectomy, these definitions become a little bit trickier because we don't know when periods stop, because if you had a hysterectomy, they're gone already. But in a woman who's having periods, basically the definition of menopause is 1 year without a period. Okay, full year without a period, without any other obvious causes. Okay, and so even when a woman goes 6 months without a period, and I'm sure many of you in the audience are saying, oh yeah, I've been there. You go 6 months without a period, you say, I'm done. And the answer is you get a period the next day. No, you're not done. Because indeed that resets the clock. So you have to say, okay, now I'm resetting that clock for another year to go without a period to say, I am definitely done with menopause. Okay, now, so that's menopause. And the other thing to remember, this is, and it goes along with, again, not to gross anybody out, but the term I use with my patients, it's the pooping out of the ovaries. That's what's going on. They're stopping working, but it's not a smooth decline. It's a jaggedy decline. So some days the ovaries will work and some days the ovaries won't work. After a year without a period, we can say they're done. Okay, pretty much as far as estrogen, okay, and progestins, okay, progesterone. So the time before that, women tend to refer, people in the field refer to that as the perimenopausal time frame. When things are changing, our ovaries are pooping out, but we haven't reached that final year without the period, okay? And all things can happen, and people describe it, things like terms riding a roller coaster, ups and downs, things like that. You'll hear all those phrases, okay? And the problem is that that can go on for quite a while, okay? People can experience perimenopausal changes for 5 years. Some people will say even more than that, okay? So these things, and again, it's hard to define because, your body doesn't go and say, hello, I'm in perimenopause, and that's what's going on. So strange things may be happening, and we're going to be talking more about those symptoms today. And the trick is finding out, is this related to hormonal changes? Or, you can't take somebody as just as a plot of hormones. Women we're going through our lives. Lots of things are happening to us in our 40s and 50s. And by the way, the average age of menopause in the United States is 51.3 years. So just to put that number in there. But things are happening to us as we're hitting our late 40s, early 50s, for even the average person in there. Lots of work changes, lots of family changes, taking care of kids, taking care of parents, taking care of our dogs. I mean, taking care of a lot of stuff. And we're trying to live our lives, and there are a lot of stressors going on. Now, if we go to the postmenopausal time frame, okay, once you've gone through that year without a period, you can say, okay, now many people will use the terms menopausal and postmenopausal interchangeably. And that's okay, that's fine. But that just means we're past the roller coaster ups and downs. I mean, we still can have roller coaster stuff, but the hormonal stuff is in a little bit more steady state at that point.
Great. And thank you for that opening, Dr. Menken. I just want to make sure that everybody here with us, please feel free to ask your questions for the Q&A, and we're going to gather them and hopefully be able to provide some of those answers. So I'm going to move on to you, Shadade, in terms of a question I have around how people experience menopause. So why do we think people experience menopause so differently from each other? I mean, you could sit in a room of 5 women and you'll hear a totally different story about the symptoms and how they're feeling emotionally and about weight gain and all these kind of things. Does the experience partly depend on cultural norms or social learnings? What are your thoughts on that?
Yeah, I think about menopause being a continuation of a spectrum of reproductive justice, right? And so we know that reproductive justice is a combination of reproductive health, reproductive rights, and an intersectional framework. And so as long as you are alive, you are operating with multiple identities, right? Mm-hmm. And some of those identities come with privilege, and some of those identities don't. And so the way that people will experience menopause, people who have a uterus, who experience menopause, really depends on where they're at culturally and socially. I think that in our society at large, and I would think I'm speaking specifically about our society in the United States, we're kind of youth-centric, right? And so when you think about living in a youth-centered culture, and you also think about that your intersectional identity as a person who identifies as a woman or femme or gender non-binary or gender fluid, and you're experiencing menopause, there are all these things that come along with that that not only are connected to your physical well-being, but also to your personhood, right? So how are you experiencing the changes in your personhood and your identity as you age in a society that doesn't value people who are older?
That is such a great answer, and just sort of like incorporating that thinking, I think could help a lot of people in the way they think about this. So that kind of speaks to my next question, which is for you, Dr. Cannon. When, excuse me, when Dr. Menken gave an overview of these things, it was the first time I was hearing it. And I think every HCP probably takes a very different approach to how they explain menopause to their patients. I wish I had been going to Dr. Menken because I'd be a lot wiser a couple of years later. So my question for you is, are all healthcare providers trained to speak with their patients about menopause? And if not, how would you go about starting the conversation with your HCP if needed, or should you even be looking for another provider?
Well, I think that it depends. Certainly, when we go through training and residency, if you are someone who's training in family medicine or in obstetrics and gynecology, before you even go beyond and go to a fellowship, you get the basics of things like menopause. But to say that are you truly trained, I think it really kind of centers around OBGYN docs or OBGYN providers like nurse practitioners, physician's assistants, et cetera, before you could really say, yeah, they're trained. And even some of them are not trained, because I think at some point it comes to what's your interest or what is your patient, population. If you're working at, maybe the local health department, you may be seeing more younger people, so you may not have the opportunity nor the interest on behalf of the clients as to whether they want to know about it. But I think that once my patients start getting into like their late 30s and early 40s, I will ask questions that will kind of lean toward the PERI, perimenopause, which is around menopause, as Dr. Minkin expressed, to see whether some of those things are creeping up on them. So, and as the annual GYN exams come and they're getting a little bit older, then I will ask more specific questions. Well, how are you feeling? And I'm the type of doc who might spend a little extra time with each patient because I want to know more about them. What's going on at home? How are the kids doing? Are you having empty nest syndrome because the kids are in college? Are you dating? If you're, older people still date. I'm 53, we're still dating. So, those things become important when you ask specific questions to determine, according to that patient's lifestyle, well, what's going on with you, and how can I help? And we just have a basic conversation, much like what Dr. Minkin said. You just sit down and have a talk, and depending on that patient, how well you know that patient may temper your approach to how you'll talk to them about menopause.
And I think, if you could respond a little bit further on that, or, in terms of treatment and treatment of symptoms. So maybe Dr. Cannon and Dr. Minkin, if you could go both share your perspective on, what are the ways to treat symptoms today in terms of hormonal methods, non-hormonal methods? What are some of the advice you give to your patients who may not have access to some of the hormonal methods that used to exist that, don't exist anymore? It would be great to hear a little bit more about that.
Okay, go ahead, Dr. Minkin.
You want me to go? Okay. I never pass up an opportunity to talk. So there are lots of options that women have out there. And of course, let's talk about the symptoms first, because of course, most people associate hot flashes as the sort of, primary menopausal symptom or perimenopausal symptomatology. And what's interesting about perimenopause particularly is that hot flashes actually may be worse in the perimenopausal transition than they are in full menopause. And indeed, the good news is, I have good news for everybody, that hot flashes do tend to get better over the course of time. They tend to be worse in the beginning, getting better over the course of time. That's the good news. The bad news is that things like vaginal dryness, the vaginal and bladder symptoms tend to get worse over the course of time. Okay, now the good news is there's stuff we can do for everything, so not to worry. But the key thing is hot flashes early, dryness and bladder issues later in general. That's just a general overview. Now, there are a lot of other things that are out there that people may not recognize as menopausal type symptomatology. Things like irritability, cognitive changes. I know we're going to have a couple of sessions on that coming up, which is great because, the question is, are these directly related to lack of estrogen? Are they related to the crummy sleep that people are getting? I ask all my patients, how's your sleep? And my patients say to me, well, it's crummy, but you're my gynecologist. Why do you care? Because I care, because this is related to perimenopause for many of my folks. So this is real and out there. Another symptom, for example, that's very common, that is grossly overlooked, is achiness. Many women experience achiness, and it's undefinable. I have had patients who've come in, many people have come in. I've been to 6 rheumatologists this year. Nobody can figure out what's wrong with me. I'm achy. This is awful. And I said, when's your last period again? A year ago. Okay. And indeed, that they were really menopausal, put them on estrogen and they're dancing away. They're having a good time. So there are a lot of different symptoms which can be out there. So of course, I'll refer everybody, of course, to Healthy Women's got a lot of information on that. Menopause.org NAMS.org, the North American Menopause Society, and my fabulous website, Madam Ovary, of course, got lots of information there on all these symptoms. So we talk about these symptoms. As far as options for therapy, I'll just start and then Octavia will take over, is that indeed we have a lot of options, okay? We have simple things, lifestyle things. So for example, one really simple thing is layered dressing. If you're getting hot flashes, okay, well, wear a shell and then wear a sweater over it. So if you get hot, you can take the sweater off and you're still clothed, so that's something easy to do. If you're getting night sweats and you're waking up drenched and you have to strip and you just keep a nightgown that's dry next to you on the floor, okay? So when you throw off your sweaty clothes, you can put something on that's dry, you won't get so cold and shivery, you can jump back into bed. And as far as bed, for example, we've saved many a relationship, I think, as gynecologists, and I'm sure Octavia's done this too pretty often, is tell people to get a dual control electric blanket. Okay, so if you're hot at night, which many of our ladies are, they're sweating, they're hot, they throw the covers off or whatever, and their partner is shivering, okay? So get an electric control, two things. These are simple and easy things. Keep your room cool and get them a blanket, so there's simple things that can be done just lifestyle-wise. And there are known triggers. People can get spicy foods that are trigger, or a glass of red wine. So either say, I'm gonna drink this glass of red wine and I know I'm gonna get a hot flash, but that's okay because I want the glass of red wine, or you're gonna avoid it. Okay, simple things that can make a big difference, okay? And then there are a host of products out there, some of which don't do much of anything, and be careful about assuming anything works. Just because it's herbal doesn't necessarily mean it's good, but there are certain products that can be very helpful for hot flashes that can work, okay? And the thing to remember is also that if they don't work, we've got lots of other things. We've got non-hormonal medications, but we have a lot of very, very safe and reliable hormonal products that are out there. And, when people talk about, some of the and you alluded to the Women's Health Initiative earlier, I think Beth mentioned it too, that, there were a lot of bad things that were said at that point, which may not have been totally reassuring to women, but we've had a lot of improvements since then of products that are available. And we've got a lot of really good options hormonally for women to delve into. Octavia, you want to take over?
Sure.
Anything you want to add there, Dr. Cannon?
Yes, they're excellent points. But I think one of the things that's most important is to don't just assume your issues are normal or they are not questions for your OBGYN. Quite frankly, a lot of women consider an OBGYN to be their primary care, and they're shocked when you say, no, not your primary care, so you got to see your primary care. But there are a lot of things. I mean, I can't look at your ears and tell you have an ear infection, but I can talk about other things that could be related really to perimenopause, or just even related to what your ovaries are doing. Hair loss, dry skin, again, not being able to sleep, mood swings. Again, there's the part about emotional health and how important that is, but it plays a big part in menopause and perimenopause. All of the things that you think might be silly, I can't tell you how many times I've had a patient saying, hey, this is not really related to my OBGYN visit, but blah, blah, blah. And I'm like, so yeah, it is related to your OBGYN visit. When was your last period again? The same thing. So certainly, this is your opportunity. When you go to the doctor, call it, or even if you call the triage nurse and you're just not sure, I don't know if I need a visit and this is what's going on. These are the things that we can try to help you manage. So again, there are natural things. I agree, some of them don't work, but you don't know until you try them. Bring a list of questions with you to the doctor. I think one of the things that we forget is that we're coming for something specific, or we might forget things. Put them in your phone. I tell my pregnant ladies that all the time because they claim to have pregnancy brain. They can't remember stuff. So put it in your phone and bring it to the office visit and let's discuss it. Those things are important. And then also just remember that you're not the only person going through this. You're not. I think many times we've been raised, depending on how old your parents may be, you just don't really talk about a lot of stuff. I mean, no one talked to me about my period. One day I was bleeding and I went, oh, and my mom was like, okay, and here's a pad for you. Good luck. I mean, like, what? You're just on your own. So that's always frightening to anybody. And then it's frightening to get into this stage of your life. What if you start losing your hair? And your hairdresser may say, well, maybe you should talk to your doctor about that. And so they might have an idea that it could be menopausal, but maybe they don't want to be the one to tell you. So little things all add up, and there are things that we talk about doing, when we're younger that we really need to continue to do. I see a question about hot flashes. Now, can they last for about 5 to 6 years, and then they stop for 2 to 3 years, and then they come back. That can be normal, but then maybe there's something else going on. Let's look at your thyroid. Let's see what else is going on. Again, revisit this. Even though you've talked to your OBGYN about it in the past, let's bring it up again. You pay us for a service. You're not paying us just to come and take a peek down below and say, good luck, goodbye. No, we want to, as a doctor of osteopathic medicine or a DO, we're treated to treat the whole patient. And as most physicians are, we care about you as a person, not as a section of your body. So talk to your providers.
Great, thank you both. Let me move back to Amish O'Day and kind of continue this conversation about talking, because we know we learn a lot more by talking with others as women than we might from the internet and other places. So, from you, who do you think people rely on to have these conversations about menopause? And, how can women find it easier to kind of cultivate these open conversations? Because these are times for women where they could be losing their hair, gaining weight, not have the same skin, like everything you work towards maybe kind of go in a pot. So, what can women do to feel better and be able to be open about this and help each other?
Yeah, that's a great question. I started my period in 1979, right? So that was 41 years ago. So Octavia and I are the same age. I'm 53, right? Okay. And so when I think about that time period, there was so much conversation happening at school with the sex education we were receiving. We were living in Maryland at the time. My mother was a nurse, so she also was from a very public health kind of place, was trying to make sure my sister and I were prepared for the physical parts of my period starting. And when my period started, my aunties kind of swooped in and were so excited. I got those 7-day-a-week panties. I got a girdle. I was like, why do I have a girdle? What am I doing this for? It was like, but there was excitement about that. But my girlfriends and I, as 12 and 13-year-olds, we talked all the time about our bodies. We talked about, did you get a training bra? What were we training? I'm not sure. But we got training bras, right? There was all of this conversation. And I also feel like at that time period, I was coming into my own identity as a person. That was the first time I ever was kissed. That was the first time I experienced sexual arousal. So it's a lot of things happening at that period of time. And so when you fast forward 41 years, and I have 2 sons, one 28, one 12. I had my last son at 41. The same people, in addition to my primary care physician, in addition to my OBGYN that I have a really good relationship with, I talk to my peers and I talk to people who are ahead of me in their generational footprint. So people who are in their 60s and 70s and 80s. And I want to understand not only what they're experiencing physically, because that physical change is important. To me, that's the most obvious thing that people can kind of wrap their minds around. But this is a holistic change that you're going through, right? So it's not just around the hot flash or the vaginal dryness or the insomnia. Insomnia is my constant partner, right? It's also how I view myself, right? My value, how I value myself. What do I think is possible for me at 53, right? And so being able to have these conversations and being intentional about these conversations is one of the reasons why I started the podcast and this project. It's like I really wanted to know what other people were thinking and what they were experiencing. And I wanted to understand what intimacy looks like for people who are either perimenopausal, menopausal, postmenopausal. What does pleasure look like? And not always pleasure derived from sexual expression, but also what are the things that you do that actually brings you pleasure? How people are managing grief. A lot of relationships shift and change and transform as you age. And so how are you managing that grief? Grief of marriages or partnerships that end, friendships that change, your work life, and what does it mean to be a menopausal person in the workplace, whether you work for a social justice organization or you work for corporate America or you're a physician, like all of these things. And so having an intentional space where people get to have this conversation with each other and share their journey and reflect what they're hearing from each other is such a powerful and important thing to be able to have. And so what I have found, because I'm centering the stories of Black women in FEMS, and FEMS are people who may or may not identify as a woman, but identify they're woman-centered. So if that's a way to explain it for you. A lot of queer folk are having this conversation. A lot of trans folk are having this conversation and are trying to figure out like, well, what does this mean for me right now? How am I navigating this? Not only the physical, but also the mental and the emotional, right?
Great. I'm going to take a couple of questions from the audience and just ask you guys. So let's start this one with you, Dr. Cannon. So apparently there's an article that has talks about the differences in ethnicity with menopausal symptoms. Have you noticed this with your patients, and how do we educate women on this reality? And Amish Shade, since you kind of focus on this as well, maybe you could, supplement the answer in terms of what you've seen with the folks that you work with as well.
Yes, I definitely have seen that. We have a good ethnic mix in our practice. So I see different types of women with, some of the symptoms are exactly the same, no matter, their race or ethnicity, and some symptoms are completely different. I think that I see more African-American or women of color complaining more about those hot flashes. They hate that hot flash. And not only do they complain about the hot flash, a lot of women are shying away from having relaxed hair or having something in their hair that'll keep them from having their hair just be unmanageable. So they're complaining about, I have this standing here and I have a hot flash and now I sweat in my scalp and now I've got to go back to the hairdresser and pay another $40. And I just paid $40 last week and I'm doing this every week. And so I think that's why a lot of women are leaning toward going what we call natural, which is the natural texture of our hair and not having a lot of chemicals in our hair. And I just started making the transition. I'm in constant prayer. I think that, there are a lot of different things. And I think a physician or a provider needs to keep that in the back of their minds, that everybody's menopause is not the same. There are some things that are alike, but there are some things that are different. And I don't think anybody would judge a provider for asking a patient, well, give me more information about what's going on with you, so that they can understand how to treat the next patient that comes along that may be the same. I think I have more white patients or patients who are more Mediterranean ethnicity who complain about aches and pains more. And it could be due to the thinning of bones. Technically, the people of color, African Americans, have bones that are a little more dense. So we don't have a lot of those muscular aches and pains. But I also think culturally, we often are told, don't complain. So your tolerance for pain is higher. So if, for example, my mom has back pain all the time from degenerative disc disease. My dad just started having arthritic changes and he's just the biggest baby ever. And my mom's like, I'm in pain every day. I don't know why your daddy's blah, 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 So it's just, I think it's a thing that's cultural and male versus female. So I do see differences, but I think, again, conversations with friends, conversations with family, talking to the elder stateswomen in your family, the more seasoned members of your clubs and memberships, to find out what's going on. And you may be the one who's starting the conversation. That's great, but make sure you talk to your provider. And Shade, I bet you have more information on that as well.
Octavia, I'm sitting here grinning because I absolutely agree with you. And Octavia and I got to connect offline as well. There's just some ways in which we have to be curious about who we're treating, right? Mm-hmm. You get to be more curious. Mm-hmm. And so if you're having a conversation with a person, and I feel like this was my experience as well as someone who gave birth to my last child at 41. It's like, what was the curiosity of my OBGYN around the different birthing experiences I had from when I was 25 and when I was 41. And the same thing holds true when you are treating a person who is coming to you who's having menopausal symptoms, right? Another thing that I think that kind of gets interwoven in there is like how people might be managing depression or anxiety as well. And how that might come up for folk. And so we know there are health disparities. This is not something that I think is in contention, right? We know that the maternal mortality rates of Black women or people who identify as a woman are unexceptionally high. And so if you're thinking about menopause, perimenopause or menopause, again, being in that spectrum of a reproductive justice life, then the same ways in which you should have autonomy, bodily autonomy, and agency, and have your physician or your healthcare provider curious about what you're experiencing to the degree that they are treating the whole person, which is why I have a soft place in my heart for DOs, because my primary care physician is a DO. He's curious. So when I sit in front of him, he's not just going to take my symptoms at face value. He's actually curious about the context of my symptoms. He also knows that I live in this country. He also knows the work I do around social justice. And so he's not just going to ask me one question. It's going to be a conversation that gives him a fuller view around, like, okay, let's get at the crux of this. And also let's kind of talk about everything that's going on. And that's going to serve us well, because like I said, this is an intersectional conversation. You're going to encounter people who are going to identify in a myriad of ways who are experiencing the end of their period and are experiencing aging, and should have as much support as they possibly can have to navigate that and be honest about what that means for them.
Great, thank you. All right, we're going to go back to treatment for a minute. Just a couple of questions that have come up from the audience. So Dr. Minkin, we mentioned a couple of times WHI, and you may want to explain what that is to people who may not know what it is. But, you know, can we talk a little bit about those concerns that still exist around breast cancer and cardiovascular issues? And can you discuss any recent research that has bubbled up?
Okay, Wendy, how many hours do we have today?
We have about 3 minutes.
3 minutes. All right. So first of all, come to my website, madameovary.com. You can read all about this and listen to the podcast here. So anyway, the Women's Health Initiative was a study that basically was terminated, at least part of it was terminated about 18 years ago. And it was a study that was designed to answer the question, does estrogen therapy after menopause help prevent heart disease? That was the real focus of the WHI. And there were some what we call observational trials which had shown that it seemed to, that women going through menopause who took estrogen seemed to have less heart disease. So this study was undertaken to investigate in a prospective, randomized, double-blind manner, does this really work? And the Women's Health Initiative, basically the first batch of data came out of it in about 2002. And what they showed was indeed they did not show protection from heart disease, okay, in women. And the first part was women who were taking estrogen and progestin who had a uterus. There's a separate arm of women who had a hysterectomy and were taking estrogen only. And what it showed is it didn't help prevent heart disease, but what they noticed in the estrogen plus progestin group was that the women who took estrogen and progestin for more than about 5.5 years had a slight, very slight, but statistically significant increased risk of developing breast cancer, being diagnosed with breast cancer. Everybody in the United States panicked, and what happened on July 9th, 2002, not that I remember the day by any chance, when the results were let out, is that every woman went to her toilet and flushed down her estrogen. And my standard line is, as much as I love estrogen, I wouldn't want to have been a fish in the United States on July 10th, 2002, with a lot of estrogen in the water. So anyway, so that was the whole thing. That was the whole thing, what happened when it stopped. Key things to remember at the WHI is it was a study of women who were basically average age about 12 years after menopause, okay? The typical woman, the average woman starting the study was 63 years old. And indeed, in what we call the observational studies, women getting estrogen as they went through menopause, they were taking it as they were getting their hot flashes. So they weren't waiting 12 years till they were all done and then taking their estrogen or estrogen plus progestin. And so there were some subsequent observational or some prospective randomized trials that were done of women who were going through menopause. The KEEPS trial is one, the ELITES trial is another one, which has shown that women who take estrogen as they go through menopause, not waiting 12 or 20 years after they've finished having periods, that it actually may confer heart protection. Okay, you're not supposed to use it for heart protection, but it seemed to be show what the original observational trials had done. The key thing about the breast cancer issue is two things that women have to know. Number one, the estrogen-only arm of the Women's Health Initiative, women who had had hysterectomy were just taking estrogen, not estrogen plus progestin, indeed had a actually slight decreased risk of being diagnosed with breast cancer. Not only was there not an increased risk, but it was actually a slight decreased risk. And that study stopped after about 7 years. They said, okay, there's like nothing here. So anyway, so women who are taking estrogen alone do not have that increased risk of breast cancer. That's number one. Number two, there are a lot of new newer modalities out there for protecting the uterus. Because if somebody does have a uterus, we have to give something like a progestin therapy to protect the lining from getting overgrowth. Because estrogen, as one of my friends describes, it's like fertilizer for a lawn, it makes it grow. So anyway, so we have to protect the lining of the uterus. But we do know, for example, that it seems in particularly some European studies that using natural micronized progesterone instead of a synthetic progestin can be helpful and may well be associated with a lower risk of developing breast cancer. The other thing is we have some newer agents out there which are terrific as far as protecting the lining of the uterus, which are not progestins, okay? And there are some serums, a particular medication called basidoxifene, which can be used with estrogen, protects the uterus, also helps protect the breast. It doesn't do bad things, it does good things to the breast. So we have a lot of new developments out there which are a lot more breast friendly. So I think the key thing for women to realize is not everything's created the same. And if you say, I really am interested in hormone therapy, you talk with your provider who can basically discuss the different options. And we've got lots of options for you to choose from. So that's the abbreviated answer.
Okay, great. And two people asked about bioidentical hormones, and one who has been on the hormones for 18 months, they've been a lifesaver. How long can she safely be on them? And then also a question about who is the right doctor to provide these hormones? Is it an OBGYN? Is it somebody else? Who should be really prescribing those?
Okay, well, bioidentical actually is not technically a real medical term. The way I tend to think of bioidenticals is that bioidenticals are the same hormones that our ovaries make, okay? And our ovaries make something called 17-beta estradiol, okay? And we've got that available. And we also make progesterone. We don't make a synthetic progesterone, we make natural progesterone. That's what our ovaries make. And we can get those. The key thing to remember about bioidenticals is that much of the standard prescriptionally available pharmaceutical grade medications that are out there for hormone therapy are indeed bioidentical, and they're approved by the FDA. The problem with many of the quote unquote bioidentical type stuff, which is made in compounding pharmacies, okay? And there's some fabulous compounding pharmacies out there and some that ain't so good out there. And unfortunately, that not all compounding pharmacies are in general not regulated by the FDA, okay? So you aren't necessarily going to know what you're getting. And they may have variable dosage, they may have variable quality, and it's not necessarily supervised. So your regular OBGYN who knows something about menopause can prescribe you very safe prescription medications, which are bioidentical. Okay, so we've got plenty of them out there. And again, there are some advantages of using bioidentical hormones for certain situations, absolutely. It's not the only drugs that are available. But the key thing is your regular OBGYN, your regular primary care person, if they've done some work in menopause, again, it doesn't have to be a doctor, your nurse practitioner, your nurse midwife, may well know about these things and are able to prescribe them for you.
Great. And one of the things I just want to remind all the folks on our session here is that there will be more discussion about hormonal and non-hormonal treatments in session 3 on October 21st. So tune back if you want to hear an even deeper discussion. So I know we're starting to get to sort of the end here, and I did want to talk with all three of you about some thoughts around menopause in general. And I think for many of us, when I talk to my friends who are going through menopause, I always look at it as a new lease on life, a new way to embrace new ways of looking at things. For many of us who have children, our kids are going off to college and we can do so much more. It may be financially advantageous to sort of, keep building our careers. And so to me, and I'm sure you, menopause is not just the physical, but the emotional and even financial. And so it's very holistic in terms of the way menopause affects our lives. So what I would love to hear you guys speak to is, how do women step forward when they're going into menopause and be proud and celebrate this and talk to their friends and listen to other women and really help each other? I know there's a lot of things I'm asking for there, but how can women approach this in a whole different way so that it's in a more positive direction for women? Who wants to go first?
I'll start.
Okay,
the one thing, one of the things that immediately came to mind when you said this is just thinking about this whole COVID mess, and in terms of, the importance of wellness and self-care. I think that, many times, I think what I've heard from friends and really thought about myself talking to other people is when you have this time of self-quarantine or this time of solitude or isolation or whatever term you would like to use to describe it, it gives you time to reflect on yourself. And if it hasn't given you that time, you need to take that time, because now as you go into the twilight years of your life, what some people like to call it, but for other people, it's more freedom. Learn to appreciate yourself and learn to think about, you matter too. You're important. Your life matters, if I can go and be corny about it in that way, because I think sometimes we dedicate ourselves to either our families, our children, our careers. We often put ourselves by the wayside, and all of that is reflected in the way that people see you. So how do you see yourself? What do you value? What do you want people to value in you? When people see you, how do you want them to feel in general, and how do you want them to feel about you? And it's not about being a phony person or trying to, be something that you're not. It's about being the best self that you can be. Love yourself first. You can't care about anything else until you have that self-reliance and that self-importance. And all of that starts with a conversation with yourself. And then a conversation with people that you value and trust. This is an example of a Zoom, we're doing Zoom meetings, Zoom conversations, talking to your friends and family on FaceTime on your phone. And that's all you have. So don't waste that. Use that time to just figure out, what do I want with my life? What do I want to do with the next 5 years? What if we're in quarantine until this time next year? How am I going to use that to my advantage? Self-improvement, self-care, just thinking about things that are important to you.
Yeah, that's a great answer, Dr. Cannon. Beth and I talk a lot about how women need to take themselves sort of out of being 7th on the list and at least making ourselves 2nd on the list, because we know there'll always be someone ahead of us. But at least if we can bring ourselves up in the ranking in terms of how we take care of ourselves and think about ourselves and put ourselves forward, that is a really healthy way of looking at things.
Absolutely.
Who wants to go next?
I'll chime in. I feel like I'm really lucky because I have kind of like 3 spheres of places where I get to kind of unpack my conversations. One, I'm in a very diverse intergenerational women's group that I've been a part of for like 20 years. And we meet once a month. Of course, that's changed because of COVID. And so we've tried to figure out how we negotiate that. But we would come together at each other's home once a month, potluck it, and the host would get to ask a question. And we've asked so many questions about aging. Like, I think the youngest person in our group is probably in her late 30s, and the oldest person is in her 70s. And so every time we come together, we're talking about all of the things that go along with life, a life well lived, right? The deaths, the joys, the grief, the shocks, the surprise, the starting over, the renaming or reclaiming of yourself. I think of menopause being a portal to a new iteration of yourself, right? And so we've explored all those things, creative things that people want to take online, and they've been afraid to talk about it. And so they have that space where they can say, I really want to do this new creative thing, but I don't know if that's something I can access. And us encouraging each other and bearing witness to each other's stories. I'm also a part of a sister circle that came online as a result of COVID. And we get together every Friday night for people just to check in. I think there's a really beautiful thing that happens when you get to bear witness to someone's story. If a person is willing to make themselves vulnerable, it kind of taps something inside of you, right? And you're like, whew. It either resonates or it's something you've not heard before that makes you think, and it makes you more curious about your own experience. And so being able to bear witness to each other's stories is, I think, a very powerful part of our healing, and also a very powerful part of us owning our personhood until we take our last breath, right? And so that's a way. And then, of course, with the podcast, and the people that I've been able to interview with the podcast are so diverse. We're talking about cis hetero Black women. We're talking about women of African descent who are queer. We're talking about folk who identify as trans or butch. We're talking about people who have never had children. We're talking about people who are great grandmothers. So it's like a very diverse group of folk who are basically saying, and yeah, I really want to have this conversation because it's necessary. We get to do something different that our mothers didn't get to do. So this is the conversations I have is for my mother, who's now deceased, right? For my mother, Mary, for her mother, Irma, for her mother, Mary, and for her mother, Elizabeth. My great-great-great-grandmother was born enslaved. And so I wonder what her experiences were as she was going through a change of life and what she was able to access and what conversations she had. And as her direct descendant, I get to have these conversations not only for myself, but on her behalf. And that feels like a really beautiful thing to do.
That's amazing. Thank you. Dr. Meakin, any additional words on how we become free birds at this age?
Terrific comments, and just a couple of stray comments to mention. First of all, that just from a strictly medical point of view, menopause can be great for some women. Okay, we've talked about the negative aspects, but for example, just this morning I saw one of my lovely patients who's going to be 53 shortly, and she's clearly perimenopausal, and she's having a lot of painful issues. Well, it turns out, one question that women always ask is pain a part of menopause, and the answer is not usually. As I said, funky bleeding and stuff like that, yeah, but not pain. And it's clear in going through her history that she probably has endometriosis. And that's what she's experiencing right now. And so the key thing is for her, and she's flunked. I've tried several different birth control pills. She gets terrible reactions to everything. And I said to her, for you, menopause is going to be a major blessing because you're going to feel good and you're going to be able to get on without taking things that don't agree with you. You're going to be happy because you're going to undergo a natural cure. So somebody who's had miserable bleeding from fibroids, somebody who's had endometriosis, menopause can be very liberating for these women. So that's a number one thing there. The other thing that's sort of sad about our society is that in general, we're a society that venerates youth. Okay. And yeah, you think of some older actresses and stuff like that are, revered and stuff like that, but there ain't too many of them. Most people tend to like the young ladies who are our models, etc. And in a society where age is revered, that the smart woman is the older woman, she's the knowledgeable person in the community, that menopause tends to be a lot easier to go through. So sociologically, because when you get to be an older person, you get to be smarter. And so that's what I tell my students, I'm old, I'm smart, it's okay. But, we may not revere it in this society, but I am old. And so the key thing is that it is a lot easier for many places where women, who are older get more respect.
Yes, very, very good. So just a couple things I'm going to merge together here. So as women get older, and obviously we've been through stressful times over the past 6 or 7 months, and our bodies react to these kind of things. So for women who are having more inconsistent or spotty periods or kind of differences in the way that they're menstruating, should they be thinking, if they're in their mid to late 40s, that this could be perimenopause, or is this a function of stress? Can you give a little advice to women what they're experiencing right now?
Talk to your doctor.
Talk to your doctor.
Because the answer is yes. It could be all of those things, but it could be something else. Could be a big ovarian cyst. It could be fibroids. It could have fibroids in the past and now they're degenerating, and there are a lot of things. So you've got to talk to your doctor so that a plan you can figure out a plan. So yes.
Great. Okay. So I think we're just about at close. I did have one additional question, not to throw things off, which is around the workplace. So obviously we've gone through monumental change in the workplace, and most people are now, sheltered in if they're not an essential worker, working from home, but plenty of people are also essential workers. But workplaces have been giving a lot more support. Now, should we be thinking about, as employers or in the workplace, giving more support to women as they enter menopause? And what are kinds of things they could do? We have one person who can answer. Who wants to answer? All right, Dr. Meakin.
There's a lot of things they can do for perimenopausal and menopausal ladies. And there have been very nice studies published, which have shown that women who are suffering from hot flashes and not treated, not taken care of, cost society a lot more money than women where you take care of their hot flashes. So if nothing else, if you want to save money, take care of your menopausal ladies. You'll have much more effective. They'll work better. They'll have less sick days, things like that. So that's number one. Even if it's not humane, it saves money. So, and I won't make a political station about that. Anyway, but the key thing is, so it saves money and it's more humane. So, and there's simple things that can be done. And there are papers published on this in the scientific literature. This is not stuff that's made up. For example, there are places where you can get to control your temperature in your room. Places in a building that can open windows. You can, lower the temperature. because menopausal women, perimenopausal women often work better in a cooler environment. So number one, let people control their temperatures. Another one is toilets. I know this sounds crazy, but if a perimenopausal woman is experiencing funky bleeding, she may need access to the bathroom more. And just if they are experiencing problems with vaginal dryness and bladder symptoms, women may have more need for getting access to a bathroom. So if you have bathrooms available, if you have water fountains available that you can have, water to cool women down that they can drink, simple things which can actually make women a lot more comfortable and a lot more productive, will save money.
Great, thank you. And there's probably a laundry list we could make right now, but we're almost out of time. And each of you are going to give you 1 minute. I know this is going to be the hardest part, just sticking within 1 minute, but one thing you want our attendees to take away, within 1 minute. What is the one thing at the end of the day you want them to know and to be thinking about? We'll start with Amna Shadeh.
I would want people to know that you're valuable, no matter how old you are, no matter how old you're going to get, and that you should be treated with respect your entire life, and you should believe, and you're an expert in your own story and what you're experiencing. And so with menopause and aging, there's a place for you to be able to have autonomy and really control what is you're experiencing. And I also want to encourage people to tell their stories, to shift the narrative that is out there around what it looks like to go through menopause, not just from a physical perspective, but also from a cultural, emotional, or mental perspective. You're not alone, and there are folk out here to support you.
Great, thank you. That's beautiful. Dr. Cannon?
I'm going to tie it in. I totally agree with what Ami Shadeh said. And then I see one last question saying, when should women be aware of what's coming, recognizing how diverse our experiences are and how little we know? So I would say, that's part of knowing yourself and self-care. And you may not know exactly when something's coming, but you should know when something is changing in you. And that's when you start having those conversations.
Great, thank you. Dr. Minkin?
Well, I will see there's a minute or two here. Anyway, most importantly, advice from the Hitchhiker's Guide to the Galaxy: don't panic. That's what I tell everybody. Bring your towel and don't panic. So the key thing is that much of what goes, there's a lot of strange things that can happen, and most of them shouldn't be terrifying. They can be terrifying to people. But the thing that I really encourage folks to do is to have a good relationship with their healthcare provider, okay? And again, it doesn't have to be a doctor. It can be a nurse practitioner. It can be a nurse midwife, your PA. There are a lot of people out there who are good. And what I encourage people to do is to get in a relationship with a provider that can, and again, continuity of care is a phrase that I think everybody here believes in. You want to be, Ami Shadeh said, I love my primary care person. I've been with this person for ages and stuff like that. If you can have an ongoing relationship with somebody, they know you, they know what you've been through, you feel comfortable chatting with them and being able to talk with them and say, I know this sounds crazy, but what's going on? And if you can have an ongoing relationship with somebody you trust, that's terrific. And if you're not getting the answers from, you don't feel comfortable, find a new healthcare provider. And that's really important. And one way to find a menopause expert, I'll make a plug here, the North American Menopause Society's website is menopause.org. And if you really need to say, I don't know what's going on and stuff like that, and I'm not getting the answers, you plug in your zip code, go on the website, and you will be given a list of menopause people who are trained in menopause that can help you.
Awesome.
Great, thank you. Well, Dr. Cannon, Ami Shadeh, and Dr. Minkin, you have been awesome. I think everybody, including myself, have learned a lot today. There is a question in the box that says, will you return for the remaining sessions? And that you were all terrific, and compliments. And I just want to make sure everybody knows there are many, many terrific speakers coming up for our next session. So please keep joining. And also don't forget to go on healthywomen.org and learn more about everything. I just wanted to say, as a woman that has gone through menopause, I learned a lot of things today that I wish I would have known when I went through it, but a lot of it was very confirming to hear. And if I could offer my points of wisdom as just a plain old woman who loves women's healthcare, is just women talk to your friends, talk to your family. One of the things I think we make the mistake about is women, especially of this generation, is keeping it all inside and weathering through and not telling them how we're feeling about these things. And when you get to talk to your friends over a coffee at a Starbucks or somewhere else, it just feels so much more confirming to know that they're having challenges with their weight, they're having challenges with their hair, they're having hot flashes, they feel moody, all these different things and emotions. If you can talk about them a lot better, seek help. And if your doctor or your nurse practitioner or someone's not helping you, then find someone else. There's a lot of people out there who can help you. 3 people right here who are ready. And then read. I just mentioned the healthywomen.org site. There are other things you could read as well. Make sure you really, make sure you go to the right resources and learn a lot. And then finally, the last thing I'll say, and one thing I've learned, is to embrace. This is a great part of your life. So many wonderful things are happening. When my children left the nest, and I was, of course, very upset for a few days, I realized this isn't my empty nest. I'm a free bird now. I can embrace all these things that I've wanted to do as a single mom for the last 22 years. So I'm going to go do them. So I would just say, take advantage of it, talk, learn as much as you can. And I just want to thank Healthy Women for putting this together, and hope that you all will fill out the survey and please come to additional sessions. And thank you again to my wonderful panelists, and I hope to see you again soon.
Thank
Thank
you.
you all.
Be well, everyone.
Yes, be well, stay well.
Bye, take care.
Bye.